হাফিজ আমি শুরু করব? Okay. Assalamu alaikum, everybody. Today is January 11. We are starting our session with cases from fellows of respiratory medicine in Bangladesh who are in Bangabandhu Sheikh Mujib Medical University. And we are having the session with two cases by Dr. Shojib. I don't, Faisal Ahmed Shojib, and then Dr. Chandora. So we have this is a collaboration of Planetary Health Academia with Bangladesh Lung Foundation and Incepta Pharmaceuticals. We have these sessions in pulmonary medicine with topic-based or case-based. Today we are doing case-based from the pulmonary fellows. With me, I have Dr. Manal Rahman, who will be also moderating this case. I have Dr. Shampriti Islam. And in our panelists, we have Dr. Aisha Sikdar, Dr. Mansoor Rashid, and we are waiting for Dr. Tazbir and Dr. Atik, who will join us later. Manal, I am asking you to start the cases with your fellows. Thank you.
Thank you very much, madam, for that introduction. So our first presenter is a final year resident of pulmonology, Dr. Faisal Ahmed Shajib. Dr. Faisal, would you kindly unmute yourself and start presenting a very interesting case?
Okay.
Yes, you can start. We can see you. But we don't see your face, but we see your slides. You can turn on your camera.
Okay.
Yes.
Respected teachers, panelists, moderator, and respected all other listeners, welcome to today's presentation. I am Dr. Faisal Ahmed Shajib, PhD resident, MD Pulmonology, Department of Respiratory Medicine, DSMMU. I am going to present my case. My case is a 32-year-old female with cough and shortness of breath. Mrs. Nazma Begum, 32 years, homemaker, hailing from Josur, got admitted here with the complaints of worsening of shortness of breath for 15 days, worsening of cough for 15 days. Patient states that she was reasonably well 15 days back, then she developed shortness of breath, which was insidious onset, exertional, and progressive in nature. Initially, it was MRC grade 1, and now it is MRC grade 3. And shortness of breath is not associated with any history of chest discomfort, palpitation, orthopnea, or paroxysmal nocturnal dyspnea. And there is no seasonal or diurnal variation and no other triggering factors. Patient has also history of cough for 15 days, which is dry, irritant, persistent in nature, and there is occasional mucoid sputum production, but no history of any hemoptysis, and there is no aggravating factor to dust, fumes, or cold, and no history of seasonal or diurnal variation. Patient has also complaints of multiple joint pain for last 4 years, which is insidious onset, gradually progressive, symmetrical, predominantly small joints of both hands, involving PIP, TIP, wrist, and MCT joints. And it was in additive manner. And there is also history of morning stiffness, which was more than 60 minutes, and joint pain aggravates on rest, and which was relieved by activity or taking analgesics. On query, patient has history of sequential color change of fingers on exposure to cold, and which was pale blue and subsequently red. This is the picture of color change of her fingers on exposure to cold. Patient has had the same symptom, that is cough and shortness of breath, for the past 6 years, and she was treated conservatively by bronchodilators and oral steroids with no significant improvements. After further investigations by HRCT test, serological study, echocardiogram, and pulmonary function test, she was labeled as a case of DPLD with pulmonary hypertension and has been treated with mycophenolate mofetil oral steroid in different doses and courses, ambrisentan 5 milligram once daily, tadalafil 10 milligram once daily, and long-term oxygen therapy for the past 2 years. Despite this treatment, she had had the several exacerbation and required hospitalization for 3 to 4 times in the past 2 years. Her symptoms have deteriorated for the past 15 days.
Thank
Patient denied any history of alopecia, oral ulcer, skin changes, fever, weight loss, and she has no history of known contact with pulmonary TB patient, contact with pets, birds, or animals, COVID-19 infection, bronchial asthma in her family, known allergy or atopy, rhinitis or rhinosinusitis, active or passive smoking. There is no other significant drug history or known history of exposure to toxin, and patient is vaccinated against COVID-19, influenza, and pneumococcal vaccine. Patient is a normally menstruating woman and history of one fetal loss 12 years back at full term pregnancy, and she has one child. And age is 8 years, enjoying good health, and patient has no history of taking oral contraceptive pill. She has no significant family history. On general examination, patient is mildly anemic, tachypneic, and oxygen saturation is 76% in room air. Patient is tachycardic and pulse is 110 beats per minute. Blood pressure is 130 by 80 millimeter of mercury. Temperature is 98 degree Fahrenheit. BMI 21.9 kg per meter square. There is cyanosis is present. There is no clubbing, JBP not raised, edema not present, and bedside urine examination reveals there is no proteinuria. On respiratory system examination, on inspection, there is slight restriction of chest movement bilaterally, and on palpation, chest expansion is reduced bilaterally. Percussion note is resonant, and on auscultation, there is bilateral basal fine in inspiratory crackles is present, which is not altered with cough. On cardiovascular system examination, palpable P2 left parasternal heave was present, and pulmonary component of second heart sound is loud. On musculoskeletal system examination, on inspection, there is digital swelling of both hands is present, and on palpation, grade 2 tenderness is present in proximal interphalangeal joint, distal interphalangeal joint, metacarpophalangeal joint, and wrist joints. But there is no significant restriction in active or passive movement. This is the picture of digital swelling of this patient. And considering the history examination finding, my provisional diagnosis is diffuse parenchymal lung disease due to connective tissue disease with pulmonary hypertension. I have found some non-specific features of connective tissue disease, but I did not found any specific features which can reflect a particular connective tissue disease. So I want to consider a differential diagnosis, that is interstitial pneumonia with autoimmune features with pulmonary hypertension. Patient has a financial constraint, that's why she was unable to do extensive investigation during this admission period, and so I am mentioning some previous investigations prior to admission. This is the HRCT chest of this patient, which reveals bilateral septal thickening, fibrosis, and cystic appearance, which reflected as the honeycombing, involving the both-sided middle and lower lobe, more prominent in the lower lobe, but apical sparing. And there is also a slight dilatation of esophagus was present. Spirometry reveals FEV1 by FVC ratio reveals restrictive pattern, and forced expiratory flow rate 25 to 75% reveals 85.6% of predicted. Lung volume reveals functional residual capacity 83.3% of predicted. Residual volume 170.2% of predicted. Total lung capacity 54.3% of predicted. Residual volume and total lung capacity ratio is 82.3, and DLCO was 23.4% of predicted. But 6-minute walk test could not be evaluated due to significant desaturation at rest. And NA was positive, and which was 3 plus fecal pattern, anti-dsDNA, anti-CCP, and RA factor was negative. In ENA profile, all the markers were negative except U1SM RNP antibody, which was positive. IGRA was negative, and HBsAg anti-HCV was negative. Now the investigation during this hospitalization, and CVC reveals patient is anemic and hemoglobin was 10.5 gram per deciliter, CRP was 8.26, ABG reveals normal, and serum creatinine reveals 0.51 milligram per deciliter, HbA1c was 6.96%, gram stain and CS reveals there is no growth, and gene expert reveals TB was not detected. And this is the chest x-ray PA view of this patient during this hospitalization, and it reveals bilateral interstitial pneumonia with enlarged cardiac shadow. This is a nail fold capillary scope finding, and here there is a dropout is present. Capillary number is 4 to 6 per millimeter. Hemorrhages were absent, avascular areas were present, neovascularization present, dilated capillaries present, and giant capillaries were present, and all the findings indicate the active scleroderma pattern. This is the echocardiographic finding, which reveals severe pulmonary hypertension, and here PSP was 70, along with some important findings, that is mild pericardial effusion, and right atrium, right ventricle was dilated, and severe tricuspid regurgitation was present. And my case meets the diagnostic criteria for mixed connective tissue disease 2019 from the Japan Research Committee of Ministry of Health, Labor and Welfare for systemic autoimmune disease. My final diagnosis is mixed connective tissue disease with DPLD with pulmonary hypertension. And after consultation with rheumatology department, she got pulse methylprednisolone followed by 1 cycle of intravenous cyclophosphamide. And now current status is cough and shortness of breath is improved, but oxygen saturation is 87 to 88% in room air at resting condition, 85 to 86% on exertion, and Krebs is present bilaterally. Now I am coming to discussion problem list and discussion point. My problem list is has two segments, that is management of pulmonary hypertension and management of the disease. In case of pulmonary hypertension, my first problem is how to categorize pulmonary hypertension in this patient, either group 1 or group 3. Is there any specific therapy for pulmonary hypertension in this case? Is there any role of immunosuppressive in the management of pulmonary hypertension in this case? And for the disease condition, my first query is what is the next step in management of this patient? Is there any role of upfront use of antifibrotic therapy in this patient? Is there any role of steroid in the management of this patient? How can treatment be modified in the face of financial constraint? And another question is areas of uncertainty in interstitial pneumonia with autoimmune features, and how to manage a patient with interstitial pneumonia with autoimmune features. Thank you all.
Well, excellent presentation, Dr. Sajib. It's like a lot of information, and I'm just thinking with limited resources over there. Even here, it is a very difficult case to manage because you have to take piece by piece of these problems. So I will start. I see Dr. Atik sir is here. Thank you very much for coming. And I know you are an expert on this. I will ask your opinion from the diagnosis perspective, and what do you think about the management process that we can start? Then I have Dr. Mansur Rashid to talk about the complications and the treatment options. So Dr. Atik sir.
Okay, thank you very much for giving me the opportunity of discussing or presenting my opinions on this case. I agree with the diagnosis of Shajib, that she is a case of mixed connective tissue disease with associated uh, ILD and also pulmonary arterial hypertension. And actually, he has also asked a question whether we should consider it as IPAF. Actually, I think we should rule out IPF from the information he has already given. Likely, it has fulfilled, the patient has fulfilled the Japanese criteria, and also the patient also fulfills the Alarcon criteria. No, no, yeah, Alarcon criteria is already fulfilled because, her URNP is high positive, and actually, in fact, in our country, in the laboratories, URNP doesn't go as high as it is mentioned, in different criteria like above 1200, above 60. We don't get it. So I think we have to consider this. And moreover, as per Alarcon, she has synovitis, she has fingers, and also she has got Raynaud's phenomenon. So three criteria. And moreover, Japanese one, we feel that Japanese one has got a higher sensitivity and specificity that is also very clearly fulfilled. Though Japanese criteria yet have not been, accepted by the West, but it is in the Asia Pacific region, we consider that that is a good set of criteria. So she fulfills, and we did not consider IPAF anymore. That is number one. And if you go for treatment, I think, for this case, immunosuppressive therapy. She is a patient, basically, she is a patient of high risk pulmonary arterial hypertension, though we know that pulmonary arterial hypertension also responds to immunosuppressive therapy. There are some, evidences in the literature, and also as per our personal observation, even I have come across a patient who had PASP 93 millimeter of mercury at the beginning, but after immunosuppressive therapy, it fell down to 35 after 6 months. So immunosuppressive therapy will be good for her, along with the supportive treatment, because she has got, our functional class, WHO class, or the modified NYHA class is also higher. And also she has predictors of high risk because her RVR dilated, a tricuspid regurgitation is there. So she belongs to a patient of high risk group. So we need to treat her seriously, and we have to treat her with mycophenolate mofetil. Obviously, she won't be able to afford, this rituximab or rituximab or tocilizumab. She cannot afford. So we have to treat her with mycophenolate mofetil or maybe cyclophosphamide. Of course, I didn't understand why they have administered first, mycophenolate mofetil and then cyclophosphamide in a very quick succession, as I guessed from his presentation. So we could wait to see the effect of mycophenolate mofetil for at least 3 months, better for 6 months. It should be treated. That is my thing. And he also put a question whether we should use vasodilators, isn't it? Shajib, was it Shajib? I
Yes, ma'am.
actually, you did you ask that? Oh, the questions are already here. Is there any role of upfront use of antifibrotic therapy?
Yes, sir.
In this regard, this is actually a disputed issue, and you know, as far as the literature and research evidences support, I think, antifibrotic therapy should be added after a 6-month trial with mycophenolate mofetil. If the FVC doesn't fall, or it fails to increase, that is one. So, and also the symptoms doesn't improve, in that case we shall consider addition of the antifibrotic drugs, not at this moment. And role of steroid, it is also a very tricky question, because the patient, she has got MCTD with a predominant component of systemic sclerosis, as you have seen in the nail fold capillaroscopy. So it will be better to avoid steroid from the at the very beginning. But if we find that symptomatic response is not satisfactory, we may add prednisolone, but below the dose of 15 milligram per day, because a higher dose may lead to scleroderma renal crisis. How can the treatment be modified in the face of financial constraint? If the patient cannot afford mycophenolate mofetil, then I think it will be better if we can arrange some support for her. And if that is also not available, in that case, we may consider cyclophosphamide in place of mycophenolate mofetil. So I think I have, and his another question was, is there any role of immunosuppressive therapy? I have already addressed that. That is, there definitely there is some role, and we must give a trial with immunosuppressive therapy before going to vasodilators. Thank you very much. I think I have given my responses to all the issues he has mentioned here.
Thank you. Thank you so much. That was very helpful. Answer to your one question, I think she kind of falls into both group 1 and group 3. So you have to separate the patient into two major problem here. The shortness of breath is definitely combination of all of this, the pulmonary hypertension, which is secondary from his her connective tissue disease, which is mixed with the Raynaud's, and altogether we might have to talk to cardiologists. I don't know who manages pulmonary hypertension in Bangladesh, to do cath and see if there's any role of what type of medication, or to avoid cost we can just directly go to the medication as sir mentioned. So Monsoon, I wanted to see what you can add to all of this question for your expertise here.
Okay, just may I interrupt for a short, for a short
Ji
comment?
sir.
In
Ji
fact,
sir.
it is quite impossible to say now that, he has a mixture of group 1 and group 3. Actually, as Shajib said, that she was evaluated before 6 years, and if an echocardiography was done at that point of time, then we can say that she also has group 3 or not. At this point, it is quite impossible, and since pulmonary hypertension is a core component of MCTD, I think we have to consider that one is definitely present. But regarding group 3, we have some pinch of salt. Thank you very much.
Okay, can you hear me, everybody?
Yes, you're
Yes.
audible.
Okay.
Yes.
Okay. Thank you very much for inviting me, and Atik sir. I think I didn't meet to be in person before, but thank you for your input. Actually, if I think this case, this is very complicated case, and the patient who is only 32 years of age and having so much difficulties, actually it is a very sad case. And considering her condition, she is having such a bad condition. I think she is mixed connective tissue disease. Can you tell me whether her SCL7T or anticentromere antibody was positive or not, or RNA polymerase 3 was positive or not? I think I did not hear those antibody, whether it is positive or not, but maybe she has also the component of systemic sclerosis, otherwise mixed connective tissue disease disorder, as RNP is positive. And think about that. Yes, her lung condition, she is very, very fibrotic. And if you see the HSCT, it is purely honeycombing, and she developed the pulmonary hypertension. So at this case stage, I'm not sure how much the immunosuppressive therapy will work on, because when a patient has fibrosis and honeycombing, it means that there is no uh, uh, active inflammation is going there. When if I do the HSCT and if I see that there are ground glass appearance, when a patient has ground glass appearance, and at this point I can think that, okay, if I give more immunosuppressive therapy, this patient might improve. So at this stage, I always need to make sure the risks and benefit component of the patient. And if I give more immunosuppression therapy, the chance of infection is very high. People over here are dying from the infection than the continuation of the disease deterioration. So we have to be very careful when we give the more and more immunosuppressive therapy. And in this case, definitely, according to the Tiksar, I also say that actually we need to make sure she does not have RNA polymerase 3 positivity. If RNA 3 polymerase 3 is positive, and if we give more and more steroid on this patient, there is chance of scleroderma renal crisis, and which might possible on this case as RNP is positive or not. So we have to think the immune suppression, the infection, and the scleroderma renal crisis. Now come to the treatment. How we can treat in this case who is having the honeycombing feature, increased pulmonary hypertension is there. So if I think in this case, in this country, USA, actually insurance is covered. When a patient come to me and I see this type of patient, actually if RNA positivity is RNA polymerase is negative, and if it is not systemic sclerosis rather than mixed connective tissue disorder, definitely I will give the pulse steroid for 3 days, and then I will decrease this directly to 60 milligram or 1 milligram per kg per day. When I see that rapidly developing, rather than in this country, actually nowadays cyclophosphamide is not used so much because of the side effect of cyclophosphamide. We are using the rituximab more than the cyclophosphamide. And if you think all the Meritson guideline article or study, you will see that rituximab work better than cyclophosphamide, but not better, not inferior to the cyclophosphamide. But if you compare to the side effects, rituximab side effects is less than the cyclophosphamide. So in this country, we use actually rituximab rather than cyclophosphamide. And in this case, whether I need to use the cyclophosphamide CellCept rather than Rituxan or not. When a patient is rapidly deteriorating, definitely I need to start the Rituxan or cyclophosphamide, then the CellCept. But if a patient is followed by outside provider and just starting of the disease, definitely I will start from the mycophenolate. If the patient continues to progress the disease, then I will start the Rituxan. But so far I can see that this patient is at the late stage of the lung disease. In this case, definitely I can try cyclophosphamide or rituximab. And if you see, actually we follow the American College of Rheumatology guideline, and there is a very nice guideline about all the ILD related to the rheumatic diseases. And they said that in this case, definitely you can use the methylprednisone. On the top of that, you can use 2 or 3 immunosuppressive therapy at a time. So you can use the CellCept plus Rituxan, CellCept plus cyclophosphamide, or CellCept, Rituxan, or the antifibrotic medicine. So as this patient is having so much fibrosis, definitely I will ask my pulmonary team and request whether they can start the antifibrotic or not. I do not think that American College of Rheumatology is saying that you cannot start the antifibrotic simultaneously when this patient is on rituximab or salsa. Definitely you can use all together, but most of the cases in my country, in USA, lots of people cannot tolerate the antifibrotic because they have so much GI symptoms. They are complaining more abdominal pain, diarrhea, and they ultimately they cannot continue the antifibrotic. In that case, another thing I also consider when a patient is acutely deteriorating, maybe, or the patient is some component of infection, I can use the IVIG. And it works very nicely. IVIG, it works very quickly, and I can give 2 grams per kg per session. So you can continue combine CellCept, Rituxan, IVIG, and the prednisone. And ultimately, in this case, the way I can see the case, the chance is very low for this patient to survive. And systemic sclerosis related ILD is the horrible thing as a rheumatologist, because the rated, if a patient has pulmonary hypertension, the mortality rate more than 50% is 3 years. So we have to be careful. And American College of Rheumatology said that when a patient start to develop the fibrosis, you have to send the patient for lung transplantation. But most of the cases, if a patient has systemic sclerosis rather than other lung disease, transplant team does not want to do lung transplant in systemic sclerosis because their chance of having the systemic sclerosis or fibrosis is more than other rheumatic disease, because all the time there is chance of more aspiration because the muscles in the esophagus does not work well. So all the time they aspirate and they quickly develop the fibrosis of the lung. So in that case, the lung transplant actually does not happen in case of systemic sclerosis. So in this case, I have to say that be careful about the steroid more and more, because the way I can see that maybe immunosuppression might not work very well in this case. Be careful, check the RNA polymerase 3. If RNA polymerase 3 is negative, then you can continue the prednisone. Otherwise, be careful about using the prednisone. Yeah, definitely you can use the cyclophosphamide for 6 months monthly IV, and after that you can switch to CellCept. If the patient does not have the money of CellCept, you can use the azathioprine, and on the top of that you can combine IVIG if you have that options. And ultimately, I do not think that there is option of lung transplant in this case. And antifibrotic, definitely you can consult the pulmonary team and they can try to start the antifibrotic, and it is FDA approved drug for ILD related to the rheumatic diseases. Any other question? Thank you.
We have some questions here in the chat box.
Yes.
Dr. Hamza has a question. Why is the patient's residual volume high? So Dr. Shajib, could you please show us again the slide on the patient's pulmonary function testing? Right. So here it says that your FVC is 44% as expected, restrictive pattern. Your FEF 2575 is 85.6%. However, your RV-TLC ratio is 82.3, which is expected. Your residual volume is 170% predicted. So, Madam, Dr. Aisha Shikdar, Madam, would you please comment on the findings in this case, whether they have any relevance to what we're discussing?
So the
Before Aishapa, if you answer, I will add few other same related question, because Dr. Hamza also asked about considering PFT and HRCT finding, is it more likely she falls into category group 3 pulmonary hypertension? In that case, would CPET be beneficial? So if you could answer Dr. Hamza's both questions with the PFT, and also please shed your lights on antifibrotic for this patient. Thank you.
Thank you very much. Thank you for inviting me to this session. Rheumatological lung disease is the most perplexing areas that we struggle with. And I'm so honored to have the rheumatologist with us in this discussion. This is actually a fascinating case. We know that RA-ILD or autoimmune ILD, when this happens, the patient's disease is probably far advanced. So before I answer those questions, I would just like to comment that the case was very well presented. Complex case summarized very well. So when your patient with rheumatological disease complains of shortness of breath, that is something that is taken very seriously. Is the lung involved? The second thing is whether there is any GI symptoms, because these will also influence the lung disease, especially coexisting reflux. Usually it signifies a poor prognosis. These patients have dyspnea, X-ray abnormalities, restrictive PFTs, and increased A gradient, keeping in mind that sometimes the symptoms may be non-specific. So the rheumatological disease can involve the parenchyma, the pleura, the airway. It can also form nodules. It can cause vascular abnormalities in the lung and also the drug toxicities. I think the two rheumatologists pretty much highlighted those. In addition, of course, we worry about smoking. So going back to your question about the RV, so there is room to breathe. So one is the restrictive lung disease due to pulmonary fibrosis or interstitial lung disease. That's one mechanism why the FVC is lowered. And then don't forget that these patients with rheumatological disease also have rib cage abnormalities. So the joints or the intercostal joints and the joints of the spine, they cause restriction of the rib cage, thereby the RV is increased. And then what was the second question? Let me see. Giti,
Do we
what
need
was...
to have a CPET because of the group 3 pulmonary hypertension? I think cardiopulmonary exercise testing, that's what he is asking about CPET.
Definitely. A CPET would be indicated to differentiate between type 1 and type 3 because the treatment is actually it's tailored to which type of pulmonary hypertension this is. It would definitely help. I think looking at this case, this is a combination of type 1 and type 3 pulmonary hypertension. And I would totally agree with the treatment. The two rheumatologists highlighted the treatment. So what do we see in the CT? In the CT, we see several changes, which is we see ground glass, we see traction bronchiectasis, we also see pulmonary fibrosis or subpleural reticulation. So when you see ground glass, that's when the immunosuppression actually helps. The mycophenolate, the azathioprine, cyclophosphamide, the CellCept, those all help in the inflammatory phase or when you see the ground glass. Once you see the reticulation that you see in this case, you have to consider combination therapy, including antifibrotics. And as Dr. Monsoon Rashid pointed out, in the INBIL trial, nintedanib was approved for autoimmune ILD. Pirfenidone can be used, but it's considered off-label. So that's what I would like to point out. And Professor Atik also mentioned that high-dose steroid can promote renal crisis. Thank you. That's all I have to comment for now on this case.
Before we go on to the next case, there's another question in the question box. What should be the optimal treatment approach if a patient with CTD has combined DPLD and small airway disease? This is from Dr. H.M. Tanvir Hassan. So would any one of our expert panelists be willing to answer that in brief?
I would take an approach of the rheumatological drugs. In addition to that, I would use combination therapy for pulmonary hypertension.
Thank you very much.
The small airways disease is due to constrictive bronchiolitis, which is also established in rheumatological lung disease. Thank you.
Thank you very much, ma'am. So just to recap what we've seen so far in complex cases like this with ILD and pulmonary hypertension, it is invariable that the patient has both group 1 and group 3 pulmonary hypertension. So in this case, we would give immunosuppressive therapy as well as anti-pulmonary hypertensive specific therapy according to the risk stratification of the patient. And there is a controversy regarding upfront combination of antifibrotic, but if the disease is progressive, then it does have a role. And if there are features of ongoing or active inflammation, we would have to consider immunosuppressive therapy, and steroids should be given very cautiously if you're considering a scleroderma pattern. So thank you very much, Professor Dr. Said Atiqul Haq sir and Dr. Mansoon Rashid, ma'am, for your kind insights into this case. And I would now like to open the floor for our next presenter, Dr. Chan Sultana Dora. Dr. Dora, would you please start your screen sharing?
সজীব ভাইয়া, please.
And your video too.
Okay, I'm stopping
please
my
stop.
screen. Yeah.
Okay, may I ask, Aisha Shikdar or Mansoon Rashid, can we consider macrolides for a small airway component of the disease? Like erythromycin?
So macrolides actually are used, well established in the literature, in COPD patients who are ex-smokers. So this is actually a different category of small airways disease. The pathology is different. There is airway constriction, whereas here it's considered infiltration of the airways. So I'm not actually sure about the macrolide. Mansoon, do you have any comments on that?
Actually, we do not use the azithromycin or macrolides, and I did not find any evidence of using these to decrease the inflammation, actually. If I find, I will try to find some evidence. If I find, definitely I'm going to let everybody know.
So our next presenter is Dr. Chan Sultana Dora. She's also a final year resident in the Department of Pulmonology. Dr. Dora, over to you to present your case on a 35-year-old female with cough and shortness of breath.
Is it, the screen is already shared, right?
Yes, we
Okay,
can see it very well. Please proceed. Thank you.
Thank you. Honorable panelists, respected moderator, and learned audience, welcome to all on my today's presentation. I am Dr. Chat Sultana Dora, Phase B resident, Department of Respiratory Medicine, Bangabandhu Sheikh Mujib Medical University. Today I am going to present a case of a 35-year-old female with cough and shortness of breath. A 35-year-old normotensive non-diabetic female presented to us with worsening of cough for 3 months, shortness of breath for 3 months, and tightening and thickening of skin for 6 months. Patient complaints of dry and distressing cough for 1 year, which become more severe in last 3 months, persistent in nature, associated with occasional scanty mucoid sputum expectoration, no history of chronic exposure to organic or inorganic dust, metal, no pet or animal contact. Shortness of breath for 3 months, which is insidious in onset, slowly progressive, modified MRC grade 3. There is no history of any orthopnea or paroxysmal nocturnal dyspnea. Patient also complains of thickening and tightening of skin for 6 months, which is progressively increasing, involving her face and both upper and lower limbs up to the elbow and knee, respectively, and also upper chest. Associated with salt and pepper pigmentation, no family history of such type of illness, no drug history. On query, patient gives history of Raynaud's phenomenon, inflammatory pain in multiple joints involving both wrists, interphalangeal joints of the hands, but no joint swelling, no deformity. Unintentional weight loss about 5 kg for last 3 months associated with anorexia. History of heartburn more after meals but no dysphagia. No bowel and bladder complaints. She has no history of contact with non-TB patient. There is no history of any skin rash, alopecia, oral ulcer, proximal muscle pain or weakness, abdominal pain, swelling, dry mouth, dry skin or fever. With these complaints, patient also consulted with a local physician, and the patient was labeled as a case of tuberculous pleural effusion by local physician and was started anti-TB therapy based on chest X-ray and pleural fluid findings, which is exudative fluid with high ADA. With this medical history, patient presented to our OPD. At that time, patient was getting anti-TB therapy for around 2.5 months, but the symptoms have not subsided. So she was referred to BSMMU for further better management. Patient is non-smoker. Her husband's she is a homemaker, and her husband's per month income is 20,000 taka. She is a nulliparous woman with normal menstrual history. There is no stillbirth or abortion. On general examination, face is smooth, shiny, tight, with salt and pepper appearance in both cheeks, nose is pinched up, and microstomia present. She is mildly anemic, pseudoclubbing present in all fingers of both hands. There is tightening and thickening of skin up to elbow in upper limbs and up to limbs and also in the upper chest. There is pseudoclubbing present and in all fingers, and there is no koilonychia or leukonychia. On general examination, vitals are normal except the respiratory rate, which is 20 breaths per minute. There is no thyromegaly, no lymphadenopathy, and no JBP is not raised. On systemic examination, respiratory system examination, right-sided pleural effusion from 8 intercostal space along the dorsal scapular line, bilateral end inspiratory crackles not altered with coughing in all other areas of both lungs. On cardiovascular examination, loud P2 and left parasternal heave present. On musculoskeletal system examination reveals grade 2 tenderness in previously mentioned joints. There is no back pain, no deformity, but some functional restriction of the fingers due to thickness of the joints. Other system, including neurological and abdominal system, reveals no abnormality. So my provisional clinical diagnosis is systemic sclerosis with DPLD with pulmonary hypertension and pleural effusion, for which I have some differentials. Is it for systemic sclerosis or tuberculosis? 1 second. Okay. Then I'm going to move to investigations. This chest X-ray is done outside BSMMU during his initial presentation. This chest X-ray showing multiple ill-defined opacity in the right side of the lung obliteration of the right costophrenic angle, and there is diffuse reticulonodular shadow in both lung fields more prominent in mid and lower zones. And pleural fluid study showing glucose 28 milligram per dl, protein 64 gram per liter, ADA 42.2 unit per liter. Cytology shows 160 cells per cubic millimeter, lymphocyte predominant, which is 85%. This investigation was done outside BSMMU, and on this investigation, the local physician was started anti-TB therapy. And when we got the patient, there was a continuation. Intensive phase was already completed, and patient was in the continuation phase. And after investigation done on BSMMU, after admission, hemoglobin 10.2 gram per dl, ESR 34, WBC 7 into 10 to the power 9 per liter, platelet 460 into 10 to the power 9 per liter. Differential count is neutrophil 65% and lymphocyte 29%. Other investigations like serum creatinine, RBS, serum uric acid, bilirubin, and SGPT, SGPT reveals no abnormality. CRP level is 26 milligram per liter. SBS AG and anti-HCV antibody were negative. On serum albumin 40 gram per liter, APTT and PT within normal range. In serological investigation, ANA and anti-SCL70 antibody was positive with high titer, and anti-DS DNA antibody was negative. And we advised for other serological tests, but patient could not do because of financial constraint. Then we advised CT chest with contrast. CT chest with contrast show multiple lung mass on the right side with right-sided pleural effusion, and there is diffuse reticulonodular shadow on both lung field, and there is also traction bibasal subpleural traction bronchiectasis, honeycombing appearance which resembling UIP pattern, and there is diffuse esophageal dilatation. This is parenchymal view. And this is CT chest with contrast, coronal section, mediastinal view, showing contrast enhancing multiple nodular shadow with right-sided pleural effusion. This is CT showing some cystic lesion, and there is tractional bronchiectasis, honeycombing appearance, and the nodular lesion present on the right side. This is the same CT. So the CT report showing heterogeneously enhancing soft tissue density masses, one of them having foci of calcification are noted at anterior and posterior segment of right upper lobe and apical segment of right lower lobe adjacent to horizontal and oblique fissures, and largest one measuring 3.6 into 3.1 centimeter. Multiple right lung mass with pleural-based nodules on the background of pulmonary TB could not be ruled out. Moderate pleural effusion on right side and interstitial lung disease which resembling UIP pattern. Then we go for CT-guided core biopsy of the lung mass. And the histopathology shows the hematoxylin and eosin stain shows infiltration with inflammatory cell, and Mason trichome stain shows diffuse fibrosis. And hematoxylin and eosin stain shows core of lung tissue with diffuse fibrosis. The histopathology report says section shows core of lung tissue. It reveals diffuse fibrosis with infiltration of acute and chronic inflammatory cells. No malignancy seen. Compatible with diffuse interstitial fibrosis favoring systemic sclerosis. The gene expert of lung biopsy, no MTB detected. Sputum examination reveals Nothing abnormality. Nail fold capillaroscopy shows active scleroderma pattern which consists of regularity irregular, capillary number 6 to 8 per millimeter, and hemorrhages present, dilated capillaries present, and giant capillaries present. Due to the esophageal dilatation, we consulted with gastroenterology department, and they advised for endoscopy of upper GIT, which shows esophagus is dilated, contained fluid, no narrowing at the lower end, no resistance during entry into the stomach. Comment early esophageal varices with motility disorder. For these esophageal varices, they also advised for liver function test, viral screening, and fibroscan of liver. Viral screening was negative, liver function test was normal, but fibroscan of the liver could not be done due to patient's financial strain. We did ultrasonography of whole abdomen, which reveals no abnormality. Echocardiography shows moderate TR with severe pulmonary hypertension. The PSP says 78 millimeter mercury. So we discharged the patient with anti-TB therapy. Anti-TB therapy patient was already on continuation phase. Tablet MMF 500 milligram BD and tablet nifedipine. And patient's current condition is the continuation, the anti-TB therapy has already completed, but patient's symptoms have deteriorated. Pleural effusion increased, patients developed desaturation on rest, and SpO2 is 96% with 3 liter per minute oxygen. So the problem list is diagnostic dilemma regarding the etiology of multiple persistent lung mass and pleural effusion. Is it due to systemic sclerosis as according to the histopathology report, or is due to tuberculosis, or is there any metastasis from any unknown etiology? Regarding further, also we want to know about from our panelists about the further evaluation and management, what we could do for further evaluation. Thank you.
Another very, interesting but unfortunate case at this age with so many things. I just wanted to ask you, when she had the tuberculosis diagnosed, was she on any kind of immunosuppression therapy, or that just came out as a symptom and diagnosed according to the symptoms? Do you remember?
Patient present this system tuberculosis.
I think your connection got poor.
I think Dr. Dora's connection is a little weak here, but I think I can answer that question. So when the patient first presented, she presented with features of pleural effusion, and it was on evaluation of the effusion when pleural fluid was drawn that it was found to be exudative lymphocyte predominant with a high ADA. And solely on the basis of those pleural fluid findings, she was started on antitubercular therapy. But when she did not improve, rather deteriorated, she went for further extensive investigations. And that is when incidentally the lung masses were found on on CT scan. And then despite the patient continuing and eventually completing her course of anti-TB therapy, there was no change in the size of the lung masses, neither a reduction nor a progression. Neither was there any change in pleural effusion. Rather, she developed severe pulmonary hypertension. Again, this was incidentally diagnosed. So that is our question now, that why are there lung masses? Why is there persistent effusion? And even a core biopsy showing a fibrotic pattern or scleroderma pattern from the lung mass. So overall, which direction is this case taking actually?
So I have a question. So the diagnosis of tuberculosis was made based on your serological studies, but there was no pathological evidence, no caseating granulomas, giant cells, or what have you, just fibrosis. So it would be, sorry, go ahead.
Madam, sorry, madam, for interrupting. It was done outside BSMMU, and we couldn't see any other report. They just show us this pleural fluid report and this chest X-ray. Even we couldn't get any CBC from that time, what they have done or not. So we couldn't find any other report, but there was no pathological report. And we done then the core biopsy from the mass lesion. We did that, and we also did the core tissue MTB, gene expert, but it is also detected MTB was not detected in the lung tissue, which we get from the core biopsy.
So I'm a little skeptical about the tuberculosis diagnosis. As you all know, I mean, you are the experts in tuberculosis treatment, most likely in Southeast Asia and maybe the world, that once you start anti-tuberculous therapy, you had 3 drug therapy for probably 3 months. The masses should have melted away, or at least gotten better. Same thing with the tuberculous pleural effusion. It usually disappears even if you do not tap the patient, if it's a mild or moderate effusion, not a large effusion. So I'm skeptical about the tuberculosis diagnosis. So what does this patient have? She has large lung masses and she has pleural effusion. So is this connective tissue disease? Scleroderma typically does not cause large lung masses or a pleural effusion. Systemic lupus erythematosus does, sarcoidosis does, and there are some other mixed connective tissue diseases that do. So this is a diagnostic dilemma, that is this all connective tissue disease? Is there any tuberculosis associated? And Geeti's point is also well taken, because sometimes these patients are put on immunosuppressives and their tuberculosis is actually becomes full-blown. So it looks like it was the other way around. The anti-tuberculous therapy was started first. So that's one of the diagnostic questions I have. And then the patient did not improve. It looks like the hypoxia is worse. The effusion is recurrent. So we are back to square one. So my question would be to the rheumatologist, what is your opinion about these lung masses and the serology on this patient?
So if Atik sir, you can go.
Okay, thank you. Actually, I was asking, whether from the other panelists, is there any rheumatologist other than me?
Yes, that's Dr. Mansur Rashid. She's working here in New York.
Okay, in that case, we can hear from Mansun Rashid first, and then I should speak.
No problem. So thing is that I agree with Aisha from the very beginning that I'm very skeptical about the diagnosis of tuberculosis. First, this patient actually meet the criteria for systemic sclerosis. Without the antibody, I can say that this patient has systemic sclerosis. How I can say that? So if I see the classification criteria of systemic sclerosis, I need 9 points to make the diagnosis. And the 9th point you can get only from the skin without any antibody, without any renal phenomena. If the patient's skin sclerosis goes beyond the metacarpophalangeal joint, from the tip to metacarpophalangeal joint. And as you say, this patient is having, say, skin thickening from the tip to the elbow. So this patient has the systemic sclerosis, no question of that. Among of all, she has also SCL70 positivity. So I would say that this patient has systemic sclerosis. Now question is that whether this patient has tuberculosis or not. In systemic sclerosis, definitely there can be pleural effusion, and the pleural effusion is exudative also. So if you do the analysis of the pleural fluid, it will be almost the same as tuberculosis. So if it is tuberculosis or not, the way you said that this patient got full treatment of anti-TB, this patient did not improve at all. I don't know at the beginning, from the very beginning, at outside, they started the tuberculosis, and at BSMMU, I think they could have done the AB stain and culture, PCR, then they could continue the anti-TB. So in this case, I'm very skeptical that this patient has tuberculosis or not, and is the patient is having any malignancy or not. So there could be a chance of malignancy in this patient. How positive we are that this patient has malignancy? When a patient has systemic sclerosis, can she have malignancy? Maybe she has, but to me, I do not think that she has malignancy. But if you want to see whether she has the malignancy or not, if it is me, I will do some PET scan. So PET scan is very good. They can give some focus if it is outside of lung. If there is any focus outside of lung, definitely you can do the biopsy from that focus. That's my point of view. But a patient who is having the high pulmonary hypertension 78, who is having UYP, who is needing 3 liter per minute oxygen supplementation, at this point, how much I want to intensify the treatment when there is the patient has the financial burdening. So at this point, if it is me, in USA, it's very, very restrictive. They will call the palliative care, they will call everybody, and there will be a big family discussion. Hey, this is the patient, this is having, what do you want? Do you want all this treatment, or do you want just continue to monitor the patient? So this is my input.
Okay, thank you very much, Manal. Now, would you allow me to say something?
Yes,
Definitely,
sir.
sir.
I would invite you for your opinion, sir.
Okay,
We want
thank
to
you.
hear you, sir.
Okay, thank you very much. I think, in fact, lack of response to anti-TB drugs and also absence of all the markers of tuberculosis, the investigations are well done. I think tuberculosis is possibly ruled out. That is number one. And there are a few cases, as far as I remember, maybe 2 or 3 cases in which, systemic sclerosis associated ILD was associated with, pulmonary nodules because of alveolitis leading to organizing pneumonia. So, and the core biopsy has ruled out malignancy and many other investigation. So I think, in this case, we should seriously consider a combination of cyclophosphamide, then low-dose prednisolone as suggested for SSC-associated DPLD, that is 15 milligram per day or maybe a bit less, along with azathioprine and also cotrimoxazole for prevention of, what we say, pneumocystis jirovecii pneumonia. And at the same time, the patient should receive, other supportive treatment measures like regular exercise, vaccination, and all the rules we suggest for prevention of infections, like following the COVID principles and maintaining good oral hygiene. And I think this should be tried. I doubt whether the patient can afford any further expensive investigation. So we have to proceed with treatment, with tentative support. So I think we need to proceed with this. Thank you very much.
If I can make a follow-up comment. So this patient actually, I would say, does not have a accurate diagnosis. I agree that all the connective tissue diseases can cause pleural effusion, but these large lung masses are very uncommon. And Monsoon's point is very well taken. Does this patient has a malignancy? If we didn't look at the patient's age, we would have said and just seen the CAT scan, as a pulmonologist, the first thing we would have said, this is malignancy. So I wonder if another biopsy would have been helpful. I know you did a core needle biopsy, but a bronchoscopic biopsy or a repeat biopsy to look for malignancy. Yes, a PET scan would be extremely helpful. Is there a focus somewhere else? And are these lung metastases? Now, in that defense, in the defense of the BSMMU pulmonary team, metastatic lung disease is usually lower lobes, multiple nodules. Some of them can cavitate, and we can look at a CAT scan and have about 80% confidence in saying this looks like metastases. This, if I was to guess, I would think if this was malignancy, this is primary lung. But this most likely, looking at the presentation, most likely is systemic sclerosis with severe pulmonary manifestation. So that's what I think. And I totally agree that at this point, maybe palliative care needs to be thought of. Now, we talked a lot about treatment of autoimmune interstitial lung disease. We talked about medical therapy. We talked about oxygen. We talked about G reflux precaution. We have to also mention pulmonary rehab and then patient education. Thank you. Those were my comments.
Thank you. Nice.
I have a question for Professor Saida Haksar and Dr. Mansoor Rashid. So is it for Aisha Madam as well, that we might consider malignancy in this case, but there is a feature that goes against it, which is the fact that these nodules maintain the same size throughout rather than progressed. So if we took malignancy off the table and went back to scleroderma, is there any form of scleroderma in which we could have massive fibrotic nodules? Is this common in your experience? Could you please shed some light on that?
Thank you very much, Manal. Actually, that is, it's very rare, but there are, rare case reports on, organizing nodules in SSC-associated, ILD. There are some reports. So, and also pleural effusion can also occur in ILD, that, SSC, in systemic sclerosis itself. And besides that, also, lung nodules may occur in systemic sclerosis in isolation, not as part of ILD. In this case, since the patient has also simultaneously ILD, I should consider that these are ILD nodules. ILD nodules may occasionally become quite big. So I think, ruling out, we can pursue some cheaper methods for further ruling out of malignancy. But as you said, the nodules have not increased over this last 6 months. So it is also testimony, I think, quite good testimony to the fact that these are very unlikely to be of malignant nature. Thank you very much.
Thank you, Professor Saida Haksar.
And systemic
Yes, doctor.
sclerosis, actually, yeah, it's unusual to have such a big nodules. So if you want to broaden the differential diagnosis for these cases, when the case did not improve with the anti-tuberculous treatment, if you think that there is a suspicion on infection, of course, what I do sometimes, if there is infection, I can do some procalcitonin. If procalcitonin is high, I can dig through the infection a little bit more. In this case, when a patient is immunosuppressed, okay, is there any cause of fungal infection over there or not? That's why TB or antibiotic is not involved, or other association of any other autoimmune disease is there. Whether do you want to check Priyanka, Siyanka or not. And Dr. Aisha said that whether you want to see whether this patient is having sarcoidosis or not, just do a little bit ACE level, vitamin D 25, vitamin D 125 level, ratio, lysozyme, a fungal test, a fungal test, a little bit procalcitonin if you want to intensify the investigation for this case when the financial constraint is there. So at this level, I would really tell you to involve the family discussion. Hey, do you have money to do all those things? The patient is not improving. The patient family member said that, yes, I have money, go for anything. So intensify the investigation, intensify the treatment. Otherwise, you have to have the broad and clear discussion with the family member. The outcome is not very good. This patient is oxygen dependent. This patient is having pulmonary hypertension. At this point, this patient, I'm not sure this patient will be the candidate of transplantation or not. So I think now is the discussion with everybody, not the patient alone.
Thank you
Thank
very
you.
much, Dr.
Just to
Mansoon Rashid, for your.
add to that
Yes, yes,
comment,
madam.
so if you have connective tissue disease of the lung, if you're very sure of the diagnosis, you do not need any additional testing. But as Monsoon pointed out, you have to rule out, you have to do a serum ACE level and all the other tests that she recommended. These are all serological tests. So when is bronchoscopy indicated? আমরা কি bronchoscopy করি আমাদের কানেকটিভ টিস্যু পেশেন্টদের রুমেটয়েড আর্থ্রাইটিস বা সিস্টেমিক স্ক্লেরোসিস? আমরা করি না। কখন আমরা করি? এই রকম অবস্থায় আসলে আমরা অবশ্যই করি। কেন করি? First, we need to establish the diagnosis. Is this really systemic sclerosis or is there something else? And with such large lung masses, your yield of transbronchial biopsy will be high. এটা ধরে নিতে হবে। Second thing is, you have to rule out alternative diagnosis, including infections. And Monsoon went through that very well. Fungal infection, যাকে স্টেরয়েড দেওয়া হয়েছে তার তো এটিপিক্যাল ইনফেকশন হওয়ার সম্ভাবনা অনেক বেশি। সেগুলা কি এসব উইয়ার্ড লাং ম্যাস করতে পারে? অফকোর্স ইট ক্যান। বাট আমি বলতে পারি, প্রফেসর আতিকও বললেন যে ওনার জীবদ্দশায় এই রকম বিরাট masses due to connective tissue দেখেছি কিনা? আমি দেখিনি, 30 বছরে দেখিনি, and it's not really well described in the literature, these lung masses. And largely, if this was my patient, obviously I would already have done a bronchoscopy. And if that did not give a diagnosis, I would have sent this patient for surgical lung biopsy. Video thoracic খুব minimally invasive করে করতে পারে। Thank you so much.
Thank you very much, madam, for your insight. We have a couple of questions in our chat box. So Dr. Hamza is asking, considering her CT findings in pleural fluid study, should IgG4 disease be considered in the differential diagnosis? Actually, in this case fulfills most of the criteria for systemic sclerosis, and IgG4 is a diagnosis of exclusion, actually. So I think we would bring that lower down in the list of differentials. And Dr. Hamza has another suggestion. Would pleuroscopy be helpful in identifying the cause of pleural effusion? As Aisha Madam pointed out, yes, probably VATS. We would have to, well, ideally, a surgical lung biopsy or even pleural biopsy would aid us in reaching a diagnosis. And there is another comment here from Dr. Atiam Tanvir Hassan. The nodules may be due to progressive massive fibrosis. In that case, the picture may be explained by Erasmus syndrome. All right. So just to summarize, this case was very instructive on several heads. Firstly, in our context, I think we have a tendency to overdiagnose tuberculosis. We shouldn't actually jump to a diagnosis of tuberculosis without evidence other than simple serology. This might make us miss some more important diagnoses. So that's the first takeaway that we have from this case. And secondly, how do we manage this case in her current status? So as Aisha Madam said, she has reached the point of palliative care, and this is where we involve the family members and her caregivers, and we decide on whether we need to progress to an actual diagnosis, whether that will benefit her in any form. And if there is a scope of diagnosis, we should consider bronchoscopy. We should consider other methods of biopsy, be it transbronchial or surgical, minimally invasive techniques, and then proceed according to that. If our final diagnosis is the very rare case of ILD, then immunosuppressive therapy takes the lead. And if our results reveal something more sinister, like a malignancy, again, this is under the realm of palliative management. So thank you very much to our presenters who took the time to sit down and arrange these two cases in such a short time, and also to our expert panelists who have really helped us open our eye about many of our shortcomings, as well as challenge our perspectives on management. And I would particularly like to thank Professor Aisha Shigdar, Madam, Professor Syed Atiqul Haq, Sir, Dr. Mansoon Rashid, Sir, and of course, Dr. Adiba Giti, Madam. And Madam, would you like to take it from here for your closing remarks?
Can you please allow Dr. Tanveer Hassan to explain this massive progressive fibrosis in systemic sclerosis and Erasmus syndrome?
Nafisa, would you please make Dr. Etiam Tanveer Hassan a panelist so that he can comment?
While they're letting him in, can you explain between pseudo-clubbing and clubbing? Or maybe one of your residents can. The patient had pseudo-clubbing?
Pseudo-clubbing. Yes, Dr. Dora, could you please explain why you said that the patient has pseudo-clubbing, and what exactly you mean by pseudo-clubbing as compared to clubbing?
Here this patient, there is in actual clubbing, it is more like presented with atrophy of the pulp. So it is more like clubbing, but it is not the real clubbing. So and there is also window, Shamroth window present. So we assume it as a pseudo clubbing.
So actually, the angle between the nail bed and the nail fold itself, that is maintained and is why it's pseudo-clubbing. But that's a very nice point that you pointed out.
Thank you, madam.
Dr. Etienne Tanveer, I invited you to become panelist. Can you accept that? I can allow to talk to, but I promoted. Or he declined to be promoted as panelist, but I can allow to talk, so you can.
I think there's a technical.
Can.
Okay,
So yeah, he's here now.
Yes.
So if he
Yes.
can talk. Yeah. Dr. Tanveer, if you could unmute. Thank you.
Yeah. Just let me join. Am I audible?
Yes.
Can you hear me?
Yes.
Yeah, thank you so much. I'm actually working as an associate professor and departmental head of hematology at Green Life Medical College, Dhaka, Bangladesh. So what I think is that this patient has got very large masses, unusually large masses, which are very unlikely to be obtained in a patient with interstitial lung disease. Although Professor Atiq pointed out clearly that it sometimes can occur rarely. It can occur rarely, but what I think is that can we think a bit out of the box? Like, there is a condition called progressive massive fibrosis, which occurs in silicosis. So there is a condition called Erasmus syndrome that actually can connect the two conditions. One is silicosis and another is systemic sclerosis. You know that silica exposure is a condition that can give rise to systemic sclerosis. And this condition is known as Erasmus syndrome. And silicosis can also give rise to a progressive massive fibrosis. So if we can combine these two things, we can actually explain the entire picture. And now we might wonder, how can silicosis occur in a patient who doesn't have any occupational silica exposure? Actually, there have been many reports in India where environmental exposure can also lead to silicosis. And in Bangladesh, the air is really contaminated. So it's not actually impossible to have silicosis even without having an occupational exposure. So I think that that's a possibility. And what we can do is that we can repeat the biopsy as one of the panelists opined, and we can also look for any evidence of crystalline silica through polarized light microscopy if possible, and also look for reevaluate the histopathological report. And also in case of progressive massive fibrosis, there is a particular pattern of the arrangement of the fibrotic strands. Maybe that has not been looked at while reporting the specimen. So that also should be kept in mind while reporting if biopsy is taken again. So that's what I wanted to say. And there is another striking point, because I have also I have encountered patients with Erasmus syndrome before, and I have always seen that that their nail fold capilloscopic findings and the lung condition severity do not actually coincide. In patients with typical systemic sclerosis, usually the NFC finding severity correlates with that of pulmonary findings or DPLD severity. But in this patient, there is severe DPLD, but the patient has just normal, early to active. The capillary count is 6 to 8 per millimeters. The count is close to normal. Normal count is 7. So its average actually 7. So we can call it early to active scleroderma pattern. But in case of this kind of DPLD, this should have been late scleroderma pattern. So actually what happens here is that Erasmus syndrome, so there is fibrosis first, and then ultimately there is progression to systemic sclerosis. But if it would have been systemic sclerosis purely, then there is simultaneous progression of NFC findings and fibrosis. So this is a striking point. I'm not saying that this is Erasmus syndrome, but when we find this kind of disparity, and also there are so many large nodules, there might be maybe we should reconsider whether there is Erasmus syndrome and consider biopsy, keeping that in mind. Thank you.
How do you treat
Actor,
Erasmus syndrome?
Sorry?
How do you treat actually Erasmus syndrome?
Actually, the Erasmus syndrome, in case of Erasmus syndrome, silicosis has no good treatment, but we can treat the systemic sclerosis component. And for silicosis, there is rehabilitation. That's the only thing that we can do. But for the systemic sclerosis component, there is treatment, and we can also assume that the interstitial lung disease is also be contributed by the development of the systemic sclerosis. So systemic sclerosis is also worsening this lung condition. So we can actually treat the systemic sclerosis component with immunosuppressive therapy and antifibrotic therapy if needed. But the silicosis component, there is no actually pharmacological treatment. We just can, arrange the pulmonary rehabilitation for the patient and good environment. If there is silicosis, then we have to rehabilitate the patient in such a way so that he can be transferred to some other areas where air is not that much polluted. So that's the best we can do.
আমি একটু কমেন্ট করতে পারি, Giti and Manal, on the Erasmus.
Yes, ma'am. Yes, ma'am. You're most welcome.
As you know, I'm in Kentucky, which is a coal mining state, and half of my patient population are smokers, half of them are coal miners, including construction workers and so on. And these patients have tremendous exposure to both coal and silica dust. So the Erasmus syndrome is a combination of systemic sclerosis and silicosis causing right middle lobe syndrome. ওই যে usually যেটা হয়, the lymph nodes are enlarged and they compress the right middle lobe, and যেহেতু right middle lobe সবচেয়ে ছোট, it collapses and causes mass-like effect. So these actually are a little different. Silicosis, as you know, is bilateral lung disease. Inhalation যদি হয় তাহলে both lung-এই হয়, and it's upper lobe predominant. এখানে right upper lobe, right middle lobe mass ছিল. So Dr. Tanvir's point is very well taken. We have to think outside the box. এই প্রশ্নটা রয়েই যাবে যে একে যদি lung biopsy করা হতো, what would we find? এটা ইরাসমাস সিন্ড্রোমের একটু unusual. আমরা যেটা দেখি, we see Kaplan syndrome, which is rheumatoid arthritis and cold workers pneumoconiosis. দুটো একসাথে মিলে Kaplan syndrome হয়, which is also disfiguring upper lobe masses. The treatment of the systemic, as he mentioned, of silicosis, there is no treatment. আমরা কি করি? আমরা COPD treatment করি, যেটা airway involvement হয়. That portion we treat with intensifying bronchodilators. And I totally agree, I would have treated with combination therapy. Thank you. আমি বোধহয় বেশি সময় নিয়ে নিচ্ছি।
Manal?
I think our assistant professor, Dr. Shampriti Islam, would like to make some comments. Yes, ma'am. The floor is open.
Am I unmuted?
Yes, ma'am, we can hear you.
Okay, I would like to differ with Dr. Tanvi because the pattern of mass and fibrosis, the pattern of fibrosis that causes the progressive pulmonary fibrosis is not present here. Madam Aisha, rightfully described the pattern is in upper lobe and middle lobe, and the fibrosis, typical fibrosis, which conglomerate into a mass is not here. And if you look into the CT scan very carefully, it is well capsulated, and there is marginal enhancement after the contrast. If Dora can show the mass with a zoom, we can understand that it is a heterogeneous intensity and with a well-capsulated mass, which is very much unlikely in case of fibrosis. So, yes, it can be a nodule, but in this size and well-rotated pattern, it is very much unlikely to be a progressive pulmonary fibrosis, in my opinion. Aisha Madam may also confirm this or may explain more better.
হ্যাঁ, মানে এক্সপোজার হিস্ট্রিটা কিন্তু সিলিকোসিসে অনেক বেশি হয়। টু ডক্টর তানভীর হাসান, এদের ইফ দে ওয়ার্ক ইন দ্যাট অকুপেশন লেস দেন 10 years, এদের কিন্তু সিলিকোসিস খুব কম হয়। মোস্ট অফ দ্য টাইম ইটস মোর দেন 10 years. সো ওই এনভায়রনমেন্টাল থেকে অবভিয়াসলি বাংলাদেশে অসম্ভব সিলিকা, অসম্ভব কনস্ট্রাকশন হচ্ছে, অ্যান্ড উইল সি ইন দ্য ফিউচার কি হবে। কিন্তু হয়তো বা যদি আমরা প্রিডিক্ট করতে পারি, স্মল সিলিকোটিক মাইক্রো নডিউলস হয়তো পাওয়া যাবে, নট দিস লাং ম্যাসেস। থ্যাংক ইউ।
Thank you very much to all the panelists. This was a really very thought-provoking discussion. Dr. Adibagiti, madam, would you like to conclude the session with your take with your final comment?
Thank you, Manal. You did excellent, and I don't think I have any new addition. Our expert panelists, Dr. Aisha Shikhtar, Dr. Atikul Haksar, Dr. Mansur Rasid, really contributed a lot to this discussion, covering, both sides of the world and how we can come into the middle and help these two patients who are very young, very unfortunate cases. But as physicians, as we like to be positive, we also like to be practical too for this management, and not just only cost but the outcomes. So I know that when I did internship palliative care or discussion with family about diseases and management was out of the question. Now we have more input, and we can show why and how we are talking and how we can manage and expectations, although both are very young female and with financial constraint. If you can talk to the pharmaceutical companies, if they can contribute medication for them, that would be very helpful. I know that it is very possible that they can do it, because most of the medications are actually much more cheaper in Bangladesh, and pharmaceutical companies have most medications that we have difficulties getting here because of the insurance cost and coverage issues. But I think you all have connections with the pharmaceutical companies who can bring medications to this kind of patients. That would be helpful. And I agree with their plan and the summaries that we have done. We have to just give it a try because they are young and see how we can do. And thank you all for your participation. It is two very, difficult case, not just because of the cases, but the way you all managed, to diagnose and do all those blood works is amazing. It is no less than here. So I really congratulate to all of you, and I hope that we can help somewhat to these patients as we present. Thank you. And thank you all for coming today and your participation. Thank you to PHA, Bangladesh Lung Foundation. And
Before you leave,
yes.
আমি একটা
Yes.
প্রচন্ড সুন্দর ছবি তোমাদের দেখাতে চাই।
জি,
We
জি।
are covered in snow in Kentucky. দেখা যাচ্ছে?
জি, it's a winter wonderland. একটু
আমাদের
উপরে তুললে গাছগুলা দেখা যাবে। হ্যাঁ।
আপা এখন স্নো তো ক্লিন করতে হবে আপা, দ্যাটস দ্য হার্ডেস্ট পার্ট।
So Kentucky এত স্নো হয় না। We are covered in 20 inches snow. তো এই এত অপূর্ব সুন্দর দৃশ্যটা শেয়ার করতে চাইলাম। আর ডোরা, তোমার কেসও ভেরি ওয়েল প্রেজেন্টেড। Manar, very impressed with you. We love Monsoon. Giti and I love Laboni. Excellent input. এবং আতিক স্যার, আপনার সাথে অনেক বছর আগে দেখা হয়েছে। আপনাকে আতিক ভাই বলবো, আমার থেকে বেশি সিনিয়র না। থ্যাংক ইউ সো মাচ। সবার প্রেজেন্টেশন প্রচন্ড, and সম্প্রতি does amazing. কিন্তু Manal, you were amazing. And Giti, of course, I mean, Giti is indispensable. Thank you, everyone. Thank you.
Thank you very much.
Thank
Thank you.
everyone.
আবার দেখা হবে। আসসালামু আলাইকুম।
Assalamu alaikum.